My name is Amanda Johnson, and this is my first patient presentation for Advanced Practice Clinicals, Nursing 5472 fall semester at UTEP. We have Miss MV, a 79-year-old female, Caucasian female that came to us for shortness of breath. She is a full code no-known drug allergy that comes to us from a nursing home. For shortness of breath. When she was at the nursing home, her nurse did rounds and found out that she was sitting in the low 80s. They added 5 liters nasal cannula to her, and they still only got her to 88 to 89%. So they called EMS to pick her up and bring her to us. She denies any sick contacts, any chest pain, coughing, but it was dry, not producing any sputum, nausea, vomiting, diarrhea. She does have confusion and Alzheimer's disease on past medical history, so it was kind of hard to get a good clinical picture from her. Family was not with her at the time of my assessment. She does have a past medical history of Alzheimer's, hypertension, afebrile, anxiety, congestive heart failure stage 3, chronic kidney disease, coronary artery disease, and obesity. Her past medical history is a left knee replacement in 2008. Family history I was unable to assess at that time. Social, she lives at a nursing home and her children do come and visit her. But she did deny that she lived at that nursing facility whenever we did ask her. Medications for during our visit, we ended up starting her on albuterol nebulizer 3 times a day for wheezing. She's on amiodarone 200 milligrams BID for her AFib. We put her on budesonide 0.5 milligram nebulizer BID for wheezing. She is on diazopril for her Alzheimer's, 10 milligrams oral nightly. She's on Lasix for her congestive heart failure. 40 milligrams QD. We started ipratropium, 0.5 milligrams TID for wheezing also, and levofloxacin, 500 milligrams IV Q48 hours for bronchitis. She's also on metoprolol, 25 milligrams oral BID for AFib and blood pressure control. Pravastatin, 80 milligrams oral nightly for her cholesterol. Prednisone, 40 milligrams oral QD for COPD exacerbation. And Rivaroxaban, 15 milligrams oral QD, a blood thinner for her AFib. Social history, she does not smoke, she does not drink, she does not use illegal drugs. She did quit about 24 years ago. Going into chart review, she was not able to tell me exactly when herself, but she had a 105 pack year history. So for assessment, patient was resting comfortably in the bed. I did have to wake her to do my assessment, so she was not as interactive. But she was able to tell me that she wasn't coughing, having any chest pain, nausea, vomiting. There were no audible wheezes at that time also. For assessment and plan, our differential, we have a pneumothorax, which could have been the cause of the desaturation, which was proved negative with a chest x-ray and listening to lung sounds since they were audible in all lung fields. COPD exacerbation is what we admitted her for. She did have that smoking history, and her ABG had a PO2 of 55 and a CO2 of 50. Cystic fibrosis was also on our differential, but since she was not producing mucus and the chest x-ray did not show any signs of cystic fibrosis, we went with COPD. On her vitals, her temperature was 98.3, her pulse was 80, which the monitor did show AFib. Respers were 20, BP was 117/73, O2 was 99%, and she does have a BMI of 32.55. Lab-wise, all the unusual labs was a elevated VUN of 31 and a potassium 3.3, which we did replace that with 40 orally. She was swallowing fine. We also were treating her heart failure with continuing her Lasix and giving her O2 as needed. For her coronary artery disease, she was getting the pravastatin. For the obesity, we did start a AHA diet for her. And for the chronic kidney disease, when she first came in, she had a acute injury, acute on chronic injury, but her creatinine was trending back to normal. We also ruled out asthma as part of the differential also, with no asthma history, with just the COPD. And when she came in, her respirations and her heart rate were normal, and she wasn't using her accessory muscles. She was just wheezing and coughing quite a bit. And that is my first patient.